up was that most patients are not recruitable and only use prone as a rescue. Now, there's not that many studies that have looked specifically at recruitability. This is one study from Italy, from Tommaso More with Antonio Pesente is the senior author. And you can see if they looked at patients, first of all, the respiratory system compliance here was relatively high, 47 and then 43, and only, by the way, 10 patients. But the RI ratio, which is an index of recruitability, anything over 0.5 suggests recruitability. You can see that these patients were actually pretty recruitable. Similarly, in a study from Italy, also Massimo Antonelli was the senior author. If you look to the recruitment inflation ratio, again, comparing COVID patients on the left to non-COVID patients, you can see they're virtually identical. By the way, if anything, the COVID patients had slightly higher recruitment to inflation ratios, suggesting greater recruitment. A study from Boston looking at risk to recruit. And just because there's an increase in PO2, PF ratio with proning doesn't mean that there's recruitment, but still pretty dramatic. If you look at the effect of proning, before proning to after proning, PF ratio went up about 75 million mercury, pretty high increase in PF ratio. Again, this doesn't prove that these patients would do better because you prone really to decrease ventilator-induced lung injury, but still suggestive that still might be worth proning. Another study that I was involved with from Germany now, looking at patient PF ratio, all supine measurements versus all prone position measurements, and you can see also there's appeared to be some benefit in terms of oxygenation to doing proning. And study I don't remember how many patients this was in, but you can see this is the oxygenation response to a lung recruitment maneuver, showing essentially no difference between COVID-19 ARDS and the non-COVID group, and the oxygen response to prone position. Again, essentially no difference between the response to COVID-19 versus non-COVID-19 or classical ARDS. Again, all these data suggestive, and this paper concluded the main features of respiratory mechanics, response to treatment, such as the oxygenation response to lung recruitment maneuvers or the prone position, and prognosis, data I haven't shown you, but it's available from a few studies, are similar in COVID-19 and non-COVID-19 ARDS. Next question is, one of the hypotheses that most patients have a low lung weight. This is a study that I was involved with from Italy, published in Lancet Respiratory Medicine, to examine the pathophysiology of COVID-19 ARDS. This was an observational study in a little over 300 patients, which we measured mechanics, D-dimers, and a number of other variables in patients, and did CT scans, quantitative CT scans, in some of them. So I'm only present you a little bit of the data. Here are the results of the, first of all, compliance. And in this study, in fact, the patients did have a higher compliance. COVID-19 patients did have a higher compliance than classical ARDS. But as I said, over the larger group of patients, 1,600 in literature, that was not the case. And importantly, the total lung weight was no different than COVID-19 ARDS than classical ARDS. The numbers here are small, though, I should point out. On the right, these were CT scans done in the COVID-19 patients. There's only 20 patients. You can see that in the classical ARDS, there's many more patients. When we broke this down by moderate and severe ARDS, you can see for COVID-19 ARDS, the total lung weight in grams was 1477, classical ARDS 1488, and for severe ARDS, you can see 1740 versus 1771. Absolutely no difference. Admittedly, the numbers are small, but there's certainly not a suggestion that the total lung weight is much lower in COVID-19 ARDS. And this is the impact of D-dimers for time reasons. I won't spend any time on that. The other prediction, the final prediction, is that early intubation would be helpful in patients with COVID-19 to prevent the movement from the L to the H. And this is based on the concept of patient self-inflicted lung injury. This is a paper we published a few years ago suggesting that patients might develop self-inflicted lung injury due to overventilation. And this occurs because of some injury, patients breathing spontaneously, they have increased drive. This leads to a vicious cycle that leads to worse injury. And the suggestion that that's the case, that, Gattinoni suggests that these patients should be intubated early. Tobin and colleagues published an opinion piece about this and cautioning about early intubation. And the conclusion was, I don't have time to go into all of the argument, but even if high tidal volume and PCLE play some role in progression of respiratory failure in COVID-19 patients, for which there is no convincing evidence, this would not provide justification for liberal use of endotracheal intubation, for which there are decades of research documenting fatal complications, strongly suggesting that early intubation is not required. There are some data in the literature on this. This is a study from Mata, published just the last couple of weeks, in which they looked at patients who received early intubation versus late intubation. Here you can see inpatient death. The percent who died was 71% in early intubation, 57% in late intubation. One could argue, of course, is the early patients were actually sicker, and that's why they were intubated early. Could that explain it? That didn't appear to be the case. First of all, you can see over time, there was no difference between early and late intubation. But importantly, when you looked at mean compliance, the compliance of patients with early intubation was actually higher than those with late intubation. So this doesn't prove that those patients weren't sicker, but it does suggest that that may not be the explanation. But certainly there's no data to suggest that early intubation actually is beneficial. And in this study, they concluded that the timing of intubation has no impact on clinical outcomes among patients with COVID-19. So finally, the last slide, how should we manage patients with COVID-19 associated ARDS? Should it be different? Should we do something different? And this is a busy slide, but I wanted to basically suggest that the considerations are the same for COVID-19 and non-COVID-19. I'm not saying that they should all be treated the same or ventilated the same. What I'm saying is if the physiologic characteristics are the same at a given point in time, then that should be treated the same whether they have COVID-19 ARDS or non-COVID-19 or classical ARDS. There certainly are some suggestions that there's an increased number of pulmonary emboli and vascular problems in patients with COVID-19, but I think for the same chest x-ray, for the same compliance, the same PF ratio, I think it's worth treating patients with COVID-19 ARDS the same as non-COVID-19 ARDS, at least until we have data that suggests that that is not the case. So we would keep tidal volumes low, intubation the same as you would now with non-COVID-19. PEEP levels, similar, I think, again, depending on lung mechanics. Prone position, I think you can still try. Haven't discussed this, but there's evidence that VV-ECMO may be equally efficacious in COVID-19 areas as non-COVID-19 areas. So thank you very much. As I said, I'm sorry I'm not able to be there in person, but I hope you enjoy the conference. Thank you.
Presentador, por favor.
Bueno, muchísimas gracias.
Okay, thank you so much, Dr. Slansky. Excellent conference. Thank you for sharing all of these recent studies where were shown the opposite parallel. Unfortunately, we didn't share the session with Dr. Gattinoni, who had to leave, but it would have been an interesting debate to talk about LH and this new vision. So as time has elapsed, we've been able to compile a bigger number of patients and experiences that probably allow us to visualize a different way of looking at the disease. So in the Q&A, let's hope you will be as enthusiastic to share questions and concerns so that we can clear those up when the time comes. Dr. Slutsky, thank you so much. And now we continue with Dr. Jorge Carrizosa. Dr. Jorge Carrizosa is an intensivist clinical epidemiologist from Fundación Santa Fe de Bogotá, and he's going to be sharing, in keeping with the topics that we've been talking about, inspiratory effort in COVID-19 patients, an essential variable for monitoring and optimizing. Dr. Carrizosa, thank you so much. You're next. Greetings, everybody. Thank you for being with us. And I want to especially thank Dr. Ferreira and Carcelis for the organization of this event. My name is Jorge Carrizosa. I'm an intensivist from Fundación Santa Fe Bogotá, and I presently work at the COVID ICU. And today we're going to talk about the respiratory effort in patients with COVID-19 infection. This pandemic has caught us into a parallel with the 50th anniversary of investigation in RDS. That's why I have this title and this perspective from Dr. Yoshida, on the base of whom many experiments and many breakthroughs in this field have been achieved and have given us the opportunity of organizing such an interesting topic, which leads us to this question. Do spontaneous respirations in patients with RDS generated by COVID-19 are acceptable in every moment, or do we have any particular considerations? Okay, we're going to provide context with this short case. This is a real patient from the COVID unit. After a long period of pulmonary recovery, later the patient was subjected to a tracheostomy. Patterns of oxygenation were fairly stable, and we start spontaneous respirations. Within the monitoring, we can see that P sub 0, and we're going to see what it is about later on, quickly changes from -2 to -9, and clinically the patient is subject to tachypnea with respiratory efforts, and we have the changes in Rx thorax as well as the secretions through the whole circuit. So here we have the Rx in our patient. We have this example from September the 2nd, still intubated, and you can see this Rx, which is not foreign to us. Now, in case of the spontaneous respirations, once the patient has been tracheotomized, you can see the change in the inflammatory and parenchymatous involvement. And of course, that goes not only with imaging changes, but also oxygenation. As I told you, oxygenation patterns had been fairly stable for a reasonable period of time, and this is the moment when we start the spontaneous respirations, and that is followed by an immediate decline in a very sudden manner. Of course, one of the main differential diagnoses that this should lead to is whether or not we are in the face of a ventilator-induced pneumonia. We have some comparable patterns with imaging damage, clinical deterioration, and oxygenation decline. I'm not showing this, but there was also a change in the system, in the patient's systemic inflammatory response. Is it always NAV? Okay, here we control these spontaneous inspirations, and we control the respiratory drive and the amplitude of neural impulses that the patient requires to be able to spontaneously breathe. In only one day, a relevant change is achieved from 11 to the 12th of September, the RX is far from being normal, and there's a reduction in the inflammatory involvement in both lungs. Pneumonia can be cured from one day to the next, probably not, and that leads us to think about a different series of conditions. Okay, here we completed the history up to this point. I'd shown you on previous slides how the the drop was going in terms of ARBA12 FO2, and there is a reduction in this response. We try to modulate the patient's response, and what ends up happening after this is a progressive hike in the oxygenation parameters, and this patient at the end of the day ended up going well from our unit. So this leads us to this term, which in English is called PSILI, patient self-inflicted lung injury, which we have also categorized as the dark side of spontaneous breathing. So here we have, again, our patient, again, awake, reconditioned, about to be released from mechanical ventilation. We received a video from the family giving thanks because the patient was already being discharged from the hospital to his home. So is it awakening or not awakening? This is the main matter in our COVID patients. So let's get back to the beginning. We've entitled this slide Physics 101, and it's part of the initial work of Dr. Yoshida and collaborators, where we started to see some important aspects. The first one is this distribution, which is not homogeneous in terms of the pulmonary inflammatory involvement. We can see from the dependent areas an inflammatory involvement, a consolidation-based involvement, and a lower rate of aeration as compared to the non-dependent areas of the lung. This leads to high levels of stress, both global and regional, and that is what is going to lead to stress elevators and also increase of transpulmonary and transvascular pressure, as clearly illustrated by this example, where we have in this panel a patient with a null breathing effort, because we can see the positive pleural pressure plus 10, the airway pressure is positive plus 30, and capillary pressure plus 12. That leads us to see that this ratio between the capillary and pleural pressure is going to have this transvascular pressure of plus 2, which is something that is not really generating high tension or trauma in the microvasculature of the lung. But you can see in this other scenario where the patient has a pleural pressure minus 20. That means that there is a very important inspiratory effort, and that excess of effort leads to a case where transvascular pressure goes up to plus 28. What happens is that this capillary is subject to some excessive tensional forces, which winds up in a conditioning of the increase of the interstitial liquid and trauma on a vascular level. The inflammatory response is strengthened, the contents of extravascular liquid also increases, and we go into this vicious cycle. Now, in terms of pathological studies, this is what we can see: patients with different levels of P plus spontaneous efforts, and you can see how in these histological cutoffs at various pulmonary spots, both independent regions, medial regions, and independent regions, the quantity of destruction that we're going to see is going to be highly variable, not only on the level of the lungs per areas, but also as per the different peeps and efforts that the patient is going to be performing. So that leads us to a review of what is happening with our patients with RDS. This is a pulmonary transection that has become the new normal, we have the famous baby lung, which is nothing else than the ratio of potentially ventilated lung left in our patient, some heterogeneous consolidated non-ventilation areas, which usually are going to go towards the dependent areas, and that's the principle of how prone ventilation has been working so well. These areas are going to condition for the compliance of the respiratory system is going to decrease the dead space, and the ventilation lung areas are going to be conditioned by excessive pressures, plateau, and excessive distension or driving pressure, which leads to high rates of deformation and stress that the lung is being subjected to. And there are also macrovascular problems with pulmonary distension changes in pulmonary structure, and that leads the load on the right atrium, and that leads to serious hypoxemia. So what does this lead us to? Okay, this quantity of poorly ventilated mass is conditioning a series of stimuli on the level of the respiratory center that is forcing the patient to make excessive efforts in cases where the patient has to start assuming his own breathing. Why is that? Because we have this series of chains that have mutual feedback based on central and peripheral chemoreceptors, mechanical receptors, and how the signal is finally received through the respiratory centers, which we've illustrated here, and also the interaction between them, which is interesting, that actually is beyond the scope of this talk, but which actually leads us to how the interaction between these various respiratory centers may actually condition various types of asynchrony and brain-lung interaction, and how the interaction between the cortex of the limbic system and the response in terms of magnitude and amplitude of the neurological response in the face of all of these stimuli. So what are going to be the determining factors of a high respiratory drive? Okay, we have hypercapnia, hypoxemia, metabolic acidosis, inflammation, atelectasia, agitation, and asynchrony. That leads us to the patient with serious ARDS at the ICU, which is going to lead to 2 or 3 of these factors, which we need to control from an early stage. We need to add the concept of ICU suffering. This paper basically highlights the fact that ICU patients may have different levels and perception of suffering. And you can see how the sensation of the lack of air happens in basically half of the patients surveyed, which is not going to be different from the first asynchronies that we're going to see in the patient in the awakening process in terms of the flow that we've been able to see within this pandemic. This series of factors leads us to a dissociation in metabolic hyperbola, where the ventilatory curve is going to be aimed at the same order. But the patient with ARDS, with the factors that we've mentioned, the curve is going to be disassociated, which leads to an amplitude of the respiratory signals being sent to the brain, trying to reach a minute volume, which in the ventilation curve does not happen. And the end result of this is an elevated drive, an excessive effort, and a higher degree of deterioration and a distance that can become worse if we don't properly intervene on this metabolic hyperbola. So this table here brings an example just to guide the order in which we should set a systematic evaluation of the patient that we try to get to spontaneous breathing. But you can use any other system. This scale is used, the respiratory distress observational chart by Dr. Campbell. We're not going to go into details. The relevant data is that patients getting 3 or more points will get an intervention, either behavioral or pharmacological, but that patient is uncomfortable, they have a sensation of dyspnea, and if we allow for the patient to progress that way, is going to end up in the silly triangle, the self-inflicted injury triangle, where an increase in the respiratory drive will end up conditioning probably inappropriate elevations of the breathing effort. As we've said, this lung is not normal, so it is going to be subject to stress enhancers. And if we add the fact that there are fairly or inappropriate levels of PEEP, that sets up the trinity of silly. So how are we going to monitor COVID-19 patients when we are thinking about awakening? The first thing is the patient's breathing drive. The gold standard is the diaphragmatic electrical activity, which is something difficult to do within the pandemic. The inputs to do that actually require an esophageal catheter connected to software that can identify the diaphragmatic electrical activity, and that implies additional invasive devices as well as extra exposure for the staff, which probably restricts this procedure at this point. But we can also evaluate it with Z0B01, which is a subrogate of the respiratory drive, where we're going to have 3 scenarios. One, below 1.5 without any additional devices. Low ones, which is minus 1.5, and a high drive, which is going to be conditioned by levels above 3.5. Okay, here's an example. We simply access to a respective menu of the ventilator, and we have to make serial measurements throughout the day. So here we have another example where in 3 consecutive measurements, we get an average to get the value that's closest to the real value. Maybe the breathing drive is high here because its average value is minus 7.1. The next step is going to be the measurement of the inspiratory effort. First the drive, now the effort. So as we mentioned, we can swiftly go and take a look on the ventilation curves and identify